So a special hand to our third years who prepared for this. It's a new sort of rendition of CakeVSPie. Dr. Steen, you are number one.
I feel like there was some rigging to that because I was at the nursing home.
Janet Manulak rigged that for you. So,
I don't know if we were supposed to make a PowerPoint.
You made it.
I made one.
well, I expect no.
Well, I didn't have the best of drugs, but I did have doxazosine. Doxazosine is a fantastic medication. We'll get into the reasons for why.
Fantastic.
First off, let me go through some disclosures. Affiliations with the below pharmaceutical companies are not present. I've received no money. But I do, in total disclosure, I am trying to get a free gift card for a coffee shop from winning this. So let's just start off with a case. If you go in clinic, I think everyone could agree that doxazosine has some benefits. And this is that guy. 71-year-old male, he's got hypertension and a little trouble urinating. Dr. Patel, what would you like to give this patient?
Doxazosine.
Well, he got lisinopril. Result, when he gets to the ED, he had no complaints because his mother taught him not to speak with his mouth full of his own tongue. However, my drug, doxazosine, is safe. Most side effects are reported as being pretty low blood pressure, which honestly, that's kind of the point of why we're having this conversation. It decreases blood pressure. And orthostatic hypotension, according to UpToDate, is not as high as I would have thought, which is only 1 to 2%. Dizziness at 5%, fatigue 8%, headache 6%. I think that would be fairly comparable across most antihypertensives. So I think you're thinking to yourself, well, doxazosine, hey, that seems pretty safe. What other drugs are safe? Clonidine. Clonidine is so safe, they even use it to treat children. They treat children with bipolar. In fact, they treated this little girl with bipolar.
Hold on a second. Hold on. Where is this going?
Or is it? Turns out this is Rebecca Riley, born in 2002, deceased in 2006.
This is internal medicine, adults only.
According to a 60-minute story, Rebecca Riley died from clonidine overdose just before her 3rd birthday. It turns out in 2010, her mother gets sent to jail. She's sending currently 2nd-degree murder charges. Her father is 1st-degree murder charges, life in prison. And if you have some free time, Kyoko Kifuji, who is the practicing physician, stopped for some time, but is now once again practicing in Boston. She currently has a health grade of 1.8 out of 5. If you have some free time, please read. It's funny. But you're saying to yourself right now, Dr. Taraga, but Dr. Steen, I would never be prescribing clonidine, or any drug for that matter, to children. I hear you knocking. So I'll let you in on the newest drug craze hitting the streets. Clonidine is a drug of abuse. According to the American Addiction Centers, clonidine's now been used to get high. It acts essentially to decrease output and outflow, increasing euphoria in both the effect and duration of opiate medications, increasing in high. Furthermore, the Mayo Clinic doesn't really think you should even have patients on clonidine drink alcohol because it causes a zombie-like effect where they have muscle paralysis, weakness, and it can cause further issues.
What was your drug?
Back to doxazosine.
Finally.
Does it work, you're asking yourself? Well, we proved it's probably safer than a few of your other options up here. According to a Norwegian post-marketing surveillance study, at 12 weeks, they did show a pretty statistically significant decrease in blood pressure of 13 and 9, 13 systolic and 9 of diastolic, without significantly affecting the heart rate. Furthermore, it also decreased indices such as total cholesterol, lowering 67%, triglycerides lowered 20%, HDL improved 2.5%, and a calculated risk of coronary heart disease after a simple 12-week course was 20.5% improved. That's pretty spectacular.
After all, population prostate.
I'm going to go ahead and just put this out right now so that they can't even talk about it. While the ALL-HAT trial reportedly demonstrated an increase in CHF and all-cause cardiac mortality, when used as a primary drug for the treatment of hypertension in patients at risk, this is not going to be your primary drug. It's an add-on drug. Furthermore, this retrospective study found that it is safe as an add-on drug when they evaluated patients who had mild CHF with NYHA class 2 or 3, and they were treated with doxazosine. Furthermore, there's other medications up here.
It's not a primary drug. So
What are you adding it on to?
useless.
Are you adding it on to one of us?
Well, so if you're going to argue, Dr. Charrier, hydralazine is also, in the same way, has almost verbatim contraindication in patients with heart failure, angina, or other drugs.
There's no use for it at all.
Well, let's get into the lanyap. Okay, this drug isn't exactly my first choice, and it's not first indicated.
Let's talk about that.
No, let's go ahead and talk about lanyap, because lanyap's really important. Lanyap's the concept of a little something extra. Doxazosin's actually been shown to improve BPH and lower urinary tract symptoms, independent of prostate size.
Nobody cares about BPH.
I care if I have BPH, whether I can treat my BPH.
Why not
So
get
Flomax
Flomax
is a similar class of medication. That is true. But in this medication, I have alpha-1 receptors leading to functional obstruction. I can block them, significantly improving urine flow
Your
rates
drug cuts out half of the population.
and lower urinary tract
Everybody
symptoms.
without a prostate.
That's a lot of people, Casey.
That's not true. Because let's go a little further. Also, I have to stop here and make a public announcement. It turns out beta blockers reduce penile vascular velocities in statistically significant manner, which leads to troubled marriages. It leads to troubled marriages, divorces, and here's a study right here specifically looking at metoprolol. It decreased the Doppler flow. It causes detumescence of the penis. You cannot get an erection, which is not a good thing.
What a word!
Useless. It renders it useless.
Furthermore, let's get some more lanyap. ED that's refractory to sildenafil monotherapy has actually been shown that doxazosin, in addition to that, can help with erectile dysfunction. Raise your hand in here if you have a patient who has maybe some difficulty urinating, is an older male. Oh, and they also have some trouble with erectile function. Guess what? I can treat a whole bunch of things. It's not just a twofer. It might be a threefer, and in a second, I'm going to show you it could be a fourfer. Turns out that it might also, there's some studies looking at it being a novel smoking cessation medication. Exciting research, exciting fellows, demonstrating decreased tobacco craving after titration from 4 to 8, showed decrease in cigarette use in the first month and continued decrease in tobacco craving subsequently.
What about hypertension?
Let's get back to clinic. Fine, we'll get back to clinic. So clinic. 66-year-old African-American male with BPH, LUTS, erectile dysfunction, tobacco use, and mild essential hypertension comes to your clinic, and they get treated with Dr. Patel.
A text message.
They get texted with lisinopril again. Lisinopril kills! This is an actual study where this is a true case report. This guy got lisinopril, went to the emergency room with angioedema. Unfortunately, they couldn't intubate him traumatically. They performed a tracheostomy. He then had a anoxic brain injury, cardiac arrest, and he is since deceased. So in closing, doxazosin doesn't kill people, and it has some additional effects.
The all-hat trial proved that.
So the all-hat trial does not prove that it doesn't work. The all-hat trial says that it does not effectively treat CHF. But we're not trying to treat CHF. HCTZ, lisinopril, those are medications that are cornerstone therapy of CHF treatment. Metoprolol. Well, it's a diuretic, so it would decrease capacity. And if anybody here sitting here could give me the mechanism that how it would have caused heart failure, there you go. I'll eat your all-hat.
What are you going to say to the geriatricians that say it's on the Beer's criteria? So
I'm going to say it's probably next to several other medications. Now, we already discussed, if you go through J&C criteria, it's not technically first line. What I'm trying to tell you, no, that patient got lisinopril and died, Janet, which I think you'll talk about a little bit later.
We'll talk about that in a minute, but it happens only in case reports. It's very, very rare.
If you go for a case,
I'm not going to die from my high blood pressure medication. And furthermore, like I said, doxazosin, for doxazosin? Oh, I didn't come across psychiatric uses for doxazosin.
Might be good. Penile, whatever that shit's called, the psychiatric.
Yeah. In the end, why I think doxazosin is a good medication, it's not going to be your first-line medicine. And I don't think anybody up here is going to complain about it. But it does have a role in specific patients who have other issues. Give me a good reason why it's not a good blood pressure lowering medication.
It doesn't work.
Why doesn't it work?
It is not a cornerstone therapy.
In all hat, it performed better than all other medications
Is it listed on the
when
Joint
looked at the
National
corollary.
Commission, 8th edition as any line of
If a
treatment
patient doesn't have
hypertension?
BPH, then
If you go back to studies from 1989, this was the cat's
I
wow.
was a year old by then. Is it on the Walmart $4 plan?
It is not. It actually costs, I think it's, I have it all written down. Neither is your drug. It is currently $12.56 at the Walmart on Ambassador Caffrey for a 30-day supply of 4 milligrams, $16.71. But then again, how much does Viagra cost? How much does treating my BPH cost? Those are other problems. Those are other problems that I can fix. My amlodipine is not going to treat other things other than give me edema. My lisinopril is just going to give me problems.
From the topic. Let's get back to hypertension.
No. I'm done. My presentation has been performed.
So I don't have a PowerPoint because my drug sets the record straight. My drug is a trendsetter. My drug defines guidelines. My drug is a drug all these guys get compared against. So I don't need a PowerPoint. That's not true at all. It is completely true. So I'm talking about valsartan, Diovan. So for a lot of the cardiologists here and across the town, Diovan is the standard of care. Diovan is the #1 cardiologist preferred ARB, which acts by obviously the angiotensin-renin mechanism.
Yeah, based on what poll, right?
I'm getting that. So I have a multi-center randomized double-blind placebo-controlled trial, Valiant trial, the Value trial, Paradigm trial, and the Xfinity trial, not the Comcast Xfinity, normal Xfinity trial, have all shown beyond doubt that valsartan Diovan is the most preferred drug for the following conditions. Not one. This is multiple birds at one stone. You have hypertension. If you have an African American male that has an allergy or cough towards angiotensin inhibitor, such as lisinopril, for example, you can put them on an ARB. They'll be completely fine. So that's one indication. Pure, good old hypertension. Renovascular disease, proteinuria. If you have a patient that you're sending for nephrology for proteinuria of whatever cause, including nephrotic syndrome, you put people on valsartan because it constricts the afferent arteriole, relaxes the efferent arteriole, thereby reducing proteinuria. That's my second indication. Third indication is newest studies show that valsartan is beneficial for dementia. All those people Casey talked about, 7-year-olds, they don't care about their prostate, they care about dementia. Because if they can't walk,
People with dementia don't care about dementia.
because if they can't,
They don't know they have dementia.
if they can't even walk, they could care less about reproducing and prostates.
You been to the nursing home?
Last but not the least, cardiovascular. Class 1A ACC-AHA Association for Heart Failure. There's a reason valsartan got combined and is now being marketed as Entresto with sacubitril, and not lisinopril, not doxazosin, not whatever else these guys are going to talk about. My drug is the one that's got a Class 1A indication by ACC-AHA, 2018 guidelines for heart failure.
What about hypertensive emergency?
Hypertensive emergency, you can give enalapril IV, Vasotec.
You're not allowed.
You can give Vasopril IV. You can do that for scleroderma renal crisis, enalapril IV.
Pregnant patient.
What?
Pregnant patient.
Not a lot of pregnant people around. There's not, except for one or two maybe. I mean, who cares about them, right?
Black box warning for maternal fetal.
So bottom line, I haven't finished my indications yet. So we have congestive heart failure. Last but not least, for African American people, valsartan is a drug of choice. JNC 8 guidelines recommend valsartan.
African American
Not
pregnant.
specifically.
JNC did not talk about pregnancy people at all. Pregnancy people, we have weaker drugs like, I don't know, alpha methyl-dopa, whatever. So I just listed out 5 indications, including dementia for ARB, such as valsartan. I'm marketing valsartan. I think Matt's talking about another ARB, but I'm going to help him out a little bit. Bottom line, like I said, I have Valiant trial.
Let me read JNC 8. It says recommendation number 7 in the general black population. These thiazides or calcium channel blockers.
Recommendation 8.7.6 talks about valsartan. 8.6. Flip the page. You probably didn't print the next page.
Wait. This is talking about patients.
I have Valiant trial, Value trial, Paradigm trial, Xfinity trial. 32,000 people.
I'll check your sources. JNC does not say that ARBs are effective among black.
I'm not from Russia. I don't know.
What's the incidence of angioedema in you?
So incidence of angioedema was significantly lower than ACE inhibitors because mine is an ARB.
You say What is it? What is the incidence?
5 point, I don't know, make
No,
a number
it's
up.
not.
I don't know. Bottom line, in summary,
Versus 3%. What's the difference? 1%.
in summary, my drug has been approved, is a trendsetter, is a showstopper, you call it whatever you want to call it. Valsartan Diavan is a cardiologist preferred drug of choice. This is the cardiology preferred drug of choice. This is a drug you will get punished, not penalized, for not putting your patients on, heart failure, exacerbation. In South Louisiana, we gotta agree, there's a lot of heart failure patients down here. So my drug
With that
is
said,
the drug of choice.
How affordable and how available is Valsartan?
What is the price you will pay for your health? What is the price you will pay for your health?
You're gonna tell that to someone that's got an income of less than $25,000 a year?
I believe my patient's health is valuable.
However,
No,
I
it's
will
not.
say, after
No,
doing
it's
the
not.
check, Valsartan was the most expensive drug on
It
the
is.
Jeffrey
How much?
It is, I agree, no questions asked. Anything
It is the
new,
most expensive.
anything new is going to be
It's the most-
expensive. Keytruda, millions of dollars.
Medicaid and Medicare doesn't even cover Valsartan.
Class 1A, that's all I gotta say. Mic drop.
Alright guys, the best drug on the market is not clonidine. Amlodipine. So this is by far the best drug. It's a first-line drug that's been around the longest
First line.
For what?
for all patients that don't have CKD, based on JNC8. If you have CKD, you need an ACE or ARB. Other than that, you can use a calcium channel blocker. Okay, see, everyone agreed here. It is a cheap drug. How do calcium channel blockers work? They inhibit calcium from entering the cardiac muscle and the...
Reading it out.
Hmm?
Why are you looking at it?
I got notes just like everyone else. It inhibits the contraction of the cardiac muscle as well as the vascular smooth muscle, which causes vasodilation and reduction in the peripheral vascular resistance, which in the end reduces the blood pressure. The onset of action takes within about 24 hours or so, and you reach the steady state within 7 to 8 days. It's eliminated renally. You don't have to worry about kidney or liver impairment versus all these other drugs, and the cost is very cheap. These guys didn't tell you how much it costs, but my drug costs $6 for 30 days, $10 for 90 days. Compared to Diavan, how much did it cost?
A lot of money.
So what are the uses for Norvasc? You can treat hypertension. You can use it for coronary artery disease. You can use it for angina, vasospastic angina, and you can also use it for heart failure too, in patients who have hypertension or ischemic heart disease.
What about hypertensive emergency?
We're talking about hypertension, not hypertensive emergency.
Really? Okay, really bad hypertension.
It's first line. You can start out with
Hypertension with end organ damage.
So
That's
what you're
hypertensive
saying
emergency.
So what you're saying is it's first line knowing you always have to add another drug. What's the difference between me being on 2 drugs and you knowing amlodipine ain't going to touch it?
Well, because no, Norvasc works most of the time. For most patients, Norvasc will work. I will never start doxazocin.
I don't know if I would say never.
What about adverse effects of Norvasc?
Let's not talk about that. But there aren't that many. Most of the complaints are just peripheral edema, and who doesn't have that nowadays? So
Aren't peripherally acting calcium channel blockers not to be used in the CHF?
no, you can use it. Yeah. Patients can take it once a day. You don't have to take it with meals. You don't have to worry about food or anything with it. You don't have to worry about kidneys or liver. And there's no absolute contraindications to it unless you have an allergy to calcium channel blockers. Speaking of, I'm glad Casey and Anish went before me. Anish, you talked about the value trial, right? Let me tell you what the value trial is actually about. You just mentioned it. You didn't really talk about it.
What is that, Valsartan?
Yeah.
Why are you talking about it?
Because, let me tell you what it was about. It was to test the hypothesis that Valsartan would reduce cardiac morbidity and mortality more than amlodipine.
ACC would recommend it if it mortality.
But you know what the outcome of the study was?
I do.
There was no difference between Valsartan and Norvasc.
why
And
would
if
you recommend Norvasc?
if there is no difference, why don't you get a cheaper drug, a drug that doesn't cause hyperkalemia or AKI or angioedema? You don't have to worry about any of those things.
If there was a difference, it would be recommended instead of my drug.
It's
Why
not.
was your drug not recommended?
There was no difference found.
Your drug doesn't even affect the RAS system.
I'm just telling you what the value trial found out, okay? And then, as you mentioned, the American Journal of Hypertension, Casey. The American Journal of Hypertension.
Yes.
You mentioned your doxazosin is only an add-on drug after, all the other drugs. So where would you add it on?
I would clearly add it on as a second-line medication.
Second
for
line?
patients who have other issues.
Not second, not third, not fourth.
I don't know where you're finding this fourth, fifth, or sixth.
Yeah.
I think it still has some ability to be useful.
I
And just like your amlodipine 5, it has its place on the bench on the side. Sit next to doxazosin.
10 milligrams. So in the end, everyone should be prescribing Norvasc in their clinics. It's a good anti-hypertensive medication. It's good outpatient. It's good to use inpatient. You don't have to worry about any real side effects. Hypokalemia, acute kidney injury, angioedema, orthostatic hypotension, or anything at all.
Do you feel
Norvasc
like
is the
more
way to
people
go.
complain about hypokalemia in your clinic, or they complain about having swelling fat legs?
Are you more worried about swelling of the legs or arrhythmias?
Well, patients are more worried about swelling of the legs.
Just give them some compression stockings.
All right, guys. It's time for the children to stop and for the adults to step up here. The big daddy of them all, clonidine. How many people here have been working in the emergency room doing the rotation with Dr. Rod, and the patient comes with hypertension? Do you want to do real-world medicine or some studies and stuff that get disproven all the time? How many of you have given a little clonidine, blood pressure goes down, give them a script, they do great? Everyone, right? Exactly. Clonidine is the best drug for hypertension. It's all right. Things happen in life.
How many people are
The
there?
peanut gallery can continue. I'll give you a real-world example after I first tell you about the mechanism of clonidine. So you guys need to know it's a centrally acting agent. What does that mean? It's an alpha-2 receptor agonist. Alpha-2. Do your research, son. Now, alpha-2 receptor agonist means that eventually it's a presynaptic. It will reduce the level of calcium, which will stop the release of norepinephrine. So that's one of its mechanisms. Another good thing to know for your boards, it might pop up, imidazoline, which is also has 3 different receptors. It works on the first one, which also helps to reduce blood pressure. It also has a really great effect on, sympathetic nervous system. So you can use it for opiate withdrawal. You can use it for ADHD. And you can also use it in many other conditions, including using hot flashes.
In fact, the new
And
recommendation is that when people come in with drugs and abuse,
if you need some sedation along with your hypertension, you can also use clonidine at that time. Now, there's a lot of stuff about the adverse effects, and it's important to talk about it, I know we picked our drugs here, but I have to be realistic. We live in a real world here. So clonidine, the most common effects, though, dry mouth, some sedation. Some patients don't mind that. Insomnia is a common thing these days. Strokes is not really one of those things. Now, rebound hypertension is a common side effect, so you have to talk to your patients. This is how you establish a relationship with your patient. Tell them, take the medication 3 times a day. They eat food 3 times a day. They can take a little pill 3 times a day as well.
Your antihypertensive causes hypertension?
No, actually, my antihypertensive,
Yes, it does.
if you had let me finish, Jason, it was dry mouth, sedation, and the third thing I was going to mention, it works so well, it can cause hypotension.
so when you take it, you can have too low blood pressure. When you forget to take it,
Just pop a little Viagra. What's the big deal with that? Now, clonidine, it's not really recommended with all these guidelines and everything. This is real-world medicine, guys. If you want, I'll give you a personal story. I had a patient here, intern year, 75-year-old, nice gentleman, no other issues, just had blood pressure issues. He was on clonidine for years. I saw him as an intern. I don't know what's going on. I said, just keep taking that. You're good. He goes to cardiology clinic. They said, clonidine is a terrible drug. They take him off. They start him on lisinopril. Blood pressure's high. He comes back. They put him on Norvasc. Blood pressure's high. He comes back. They put him on labetalol. Blood pressure's still high. He gets sick of it all. Goes to some emergency room out in Kaplan, Eunice, whatever it might be. They put him back on the clonidine. His blood pressure's perfect again. Sometimes we get too caught up in all this. They'll be on 3-4 agents. Clonidine, 0.1, 3 times a day. Works every time. You have some issues, crank it up with 0.2, 0.3, and you'll be good. Trust me, this is real world medicine.
All right, game over. So I've got losartan, which is by far the best. I don't know what these guys are talking about. One, it was actually listed on the WHO model of essential medicine, which came out in 2017. WHO model compares WHO model of essential medicine, so it compares the effectiveness compared to the cost. And in it, lisinopril is not mentioned. Neither was valsartan, by the way. The
When was this study?
ARB mentioned was, this is 2017, up to date.
Okay, you're my cousin anyway.
And the reason why too is because it actually, the cost per month is about $1.13 listed on the National Average Drug Acquisition Cost, the NADAC, which is also in 2017 that it came out. So being that's very cost effective, what's the benefit? Across the board, it's all spent everything. Look at the guidelines that came out too lately. Talks about heart, excuse me one second. Treatment in, sorry.
While you're working on that, in the meantime, I was able to Google search quickly.
Okay.
I found that there was a study that reviewed all ARBs against each other, and it turns out, I hate to say it,
We're going to come back to that later, actually. So it actually comes back that losartan works out better.
more statistically stronger effect at lowering blood pressure. And they also reported that it had increased drug efficacy and compliance.
So actually, we'll come up to that too. Actually, it's a good comparison because we'll talk about that in just in a second. So when it compares to other medicines, especially like those with ischemic heart disease, what to use what. So the goal is blood pressure less than 130/80. Use a beta blocker or ACE inhibitor. It doesn't say anything about a calcium channel blocker up until you know for sure it's not acutely going on or not acutely decompensated. You avoid the calcium channel blockers. So no Norvasc during those episodes. Also during heart failure with reduced EF, it's one of the best medications to use. I'm going to skip forward. So also useful in chronic kidney disease, like Condi said. All those good stuff about it. But the main thing... So that actually goes back to the... gosh dog it, ELITE trial. So the ELITE trial did say that. Back in the 1990s, ELITE trial did show that ACE inhibitors were better at first, and that you can only use ARBs for backup plan. Key to that, though, is actually they used a very low dose of losartan in that trial. It was 50 milligrams only. So come to find out, this is actually my big point that I want to make. So what's the difference between the ARBs? Are they surmountable? The angiotensin 2 receptor or 1 receptor agonist. Can you overcome that amount with increasing doses? Or once you start it, is that it? Like you can't, the more you add, does it benefit and block the receptor more? So come to find out, losartan and valsartan both can, they're both surmountable. So actually the more dose you give can block it more, which goes back to the Valiant trial that Condi Med had, which his dose was doubled for that trial. That's why it came out well, when losartan wasn't against the ELITE trial. Max dose is, it comes in 50 and 100. But actually...
100 milligrams reduced blood pressure systolic, 12.01 and 9.37 for diastolic compared to valsartan, which is in the 15s both ways. In fact, in my chromic doxycycline drops it down 13.
But drops it, so it actually doesn't take effect until about 4 to 6 weeks later, so it doesn't matter what the acute drop is. So, and then so the trial that I was talking about is called the... I lost it, see now. It doesn't matter. So,
Doesn't matter.
losartan, it works better than valsartan because you can increase the dose to make it actually overcome the receptor, which if you plug that into the trials, it shows benefit over valsartan, and that's all I got.
All right.
Okay, all right. Okay, I chose metoprolol. Well, as you guys know, it is a beta blocker. Yes, I did. It's a low pressure. Also, Troprol XL. Okay, it comes in both oral and IV form. It's a short acting and long acting. You should know this. Okay, mechanism of action. All right. It's important to know the mechanism of action of this for this drug because it blocks the action of catecholamines, epinephrine and norepinephrine, or beta adrenergic receptors. So beta receptor there, 1, 2, 3. Okay, beta 1 receptors they are in the heart and kidneys. When beta 1 stimulation, what happens is your heart rate increase. You get increased contraction, increased cardiac conduction. In the kidneys, it increased renin, it increased blood pressure. Beta 2 receptor, they're located in your internal organs, okay, intestine, liver, skeletal muscle. So when they are stimulated, what happens? They cause vasoconstriction, increase the blood pressure, and it causes tremors in the skeletal muscle. So when you're stressed, when Dr. Sells call you in the office, say, I need to talk to you, and you're like, oh my God, okay, and he says, no, come in next week, and you're thinking, what did I do wrong? And you'll say, but this system is take over, then you get high blood pressure. Don't worry, I have beta blocker, okay? So it treats hypertension. How? It blocks the sympathetic nervous system on your heart and on your kidneys, okay? So this beta blockage of renin release, it leads to reduced aldosterone via renin, angiotensin, aldosterone system. It decreases blood pressure. It decreases sodium and water retention. And not only that, it also treats angina from negative inotropic and chronotropic effect. It decreases cardiac workload and it decreases oxygen demand. And also, chronic.
It's funny you wait. It's funny you bring up angina.
Okay, I'll talk about ED. I'll talk about ED. Okay.
Metoprolol with angina.
What?
What are you gonna say to Casey who's worried about ED?
So metoprolol.
I'm a little bit more worried about this.
I know. Okay, I'll tell you. It comes in. Okay, metoprolol does have little side effects, but I'll tell you later. Okay. Okay. No, it's not life-threatening. All right. And if you use beta,
warning against abrupt
but it's
discontinuation as it exacerbates angina and can lead to myocardial infarction.
no. But it decreases cardiac output and decreases oxygen demand. And also for arrhythmia, you can use it for SVT, VTAC, and AFib. I don't think one of your drugs don't do that. Okay, it blocks sympathetic. Yeah. AFib you can use for arrhythmia. Yeah. I'm Jason. All right. Beta blocker, it has #1 role in prevention of heart attack. In people who already has heart attack, it increases the chance of living longer and better with heart failure. And you guys can do that. Yes, and so beta blocker, just like other anti-hypertensive drug, it does have side effects. Little side effects, but it's not that annoying, I think. Okay? But it's not life-threatening. You need to think about the mortality benefit of beta blocker. Okay, now let's talk about beta blocker and ACE, right? ACE is a good drug, initial drug, but remember, angiotensin system is activated in response to renal sympathetic system. Increase renin, beta blocker can take care of that. Angiotensin 2, increase norepinephrine, and increase heart contractility, beta blocker take care of that. But it doesn't have cough, angioedema side effects, and you can take it in pregnancy. ACE inhibitor and ARBs, you cannot take it in pregnancy, but you can take it in pregnancy. Beta blocker, you can take it. All right? Yes, you have other choices, but it is safe. Okay, what about amlodipine, calcium channel blockers? Okay, calcium channel blocker does reduce blood pressure, but what happened? Beta receptor reflex increase catecholamines, increase sympathetic system, leading to heart rate. Increase heart rate, increase contractility. Beta blocker, you need beta blocker for that. And calcium channel blockers, they are contraindicated in cardiomyopathy. Beta blockers, you can use it for cardiomyopathy. All right. Alpha blocker, doxazosin, Steen. Look at the Steen. Yes, Steen. I'm a woman. I don't smoke. I don't need doxazosin. All right. Okay, all right. And hydrolysis. Oh, hydrolysis. Wait. Hydrolysis. Look, vasodilator. Hydrolysis is a first-line drug for patients who are pregnant, who has hypertensive emergency. Very good. But you can also use beta blocker too. And when you use hydrolysis, you use...
That's different.
Yes, hydrolysis, and you can...
is not first line in pregnancy hypertension.
It is not the first line, but you can, yes. Labetalol is a beta blocker. It's a person.
What about perioperatively?
Perioperatively?
Oh.
Okay. You have to go together. Vancomycin. Okay. Never forget my Zosyn, all right? Okay. Hydrolysis, it can cause reflex tachycardia. You cannot use it in tachycardia, but beta blocker you can. All right. And clonidine, you can cause rebound hypertension. Yes, it's the last result. You have to use other medication before, and it's a side effect.
I'm still stuck at why we're
No,
not
what
using
happened is when you have a moderate or severe blood pressure, you have to use beta blocker too.
And I can use it to treat somebody with esophageal varices. Metoprolol?
Really? Does JT8 recommend microbiology work?
Huh?
Does JT8 recommend microbiology?
It's a good drug. Okay, and diuretic, hydrochlorothiazide, okay? It prevents absorption of sodium and water retention. What happened is it decreases potassium, so hypokalemia leads to arrhythmia, fibrillation. It can cause sudden death. So hydrochlorothiazide, diuretic is good, but you also need other blockers, other medicine, okay?
Diabetics,
So
they mask their hypoglycemic awareness.
yes,
They're
it
just
does.
passing out.
It does mask. So you need to monitor that. But so beta blocker, okay, it does treat heart failure. It's good for hypertension,
With
coronary
beta blocker.
artery disease. I'm talking about metoprolol, beta blocker. Okay, coronary artery disease, stable angina, but clonidine is contraindicated in heart failure. Dalzazine is contraindicated in heart failure. Okay, so if it's remember, it treats hypertension. It does have mortality benefit for people.
Hydrochlorothiazide.
HCTZ.
However you like to say it. Okay, so let me tell you why I think my drug is the best. Well, why I know my drug is the best. So it's one of the initial drugs of choice for hypertension. So I have a few questions for everyone. Does anyone know the poverty level in Louisiana? Guess.
30%.
Okay, so it's really high. So about 890,000 of Louisiana residents of the 4.7 million residents live below 24,000. So that's a family of four. So just imagine.
HCTZ and lisinopril are both on the $4 menu.
You're right. It's on the $4 menu, but wait. So it's important. So most of your patients, how many of your patients are basically on Medicaid or don't have any insurance? Anyone?
What about the alcohol contraction?
We're not worried about that right now. Worry about how many people do you actually have that's like
How many times do you use HCTZ to treat the swelling from his?
a lot. So what's important is that hydrochlorothiazide is $4, guy. $4. That's like hardly any money. Does anyone know how much a gallon of milk costs? People with kids?
$5 a whole food.
Exactly, right? Yeah. So if you basically don't have any money, you have to decide between a gallon of milk and what? Medication, right?
Blood pressure medicine.
Okay, so you would pick the $4 medication, right? So let me tell you about hydrochlorothiazide. It's well absorbed from the GI tract. It basically absorbs sodium in the distal convoluted tubule. And basically, it helps the kidney's ability to retain water. It decreases the kidney's ability to retain water. So basically, you want to use it for patients with edema. Any of your patients have problems with edema?
Yes. Yeah, lots of
My diabetic patients are my gout patients or my.
Yeah, but we're not worried about gout. Come on. One toe, you have 10 toes. It hurts one toe. Not a big deal. So we know it does have side effects, but the most important thing is that hydrochlorothiazide works really well. Okay?
Until they turn to older females, in which case you can't use it because they have terrible problems with hypokalemia.
Yeah, but you can give them potassium. Give them bananas. Not a big deal.
Bananas are expensive. Eat a banana.
No, bananas are expensive. They're like 42 cents a pound.
And increased hyperglycemia and hyperlipidemia, and increase uric acid.
Give them a statin. $4.
But then all your cheap medication.
Cheap! It's cheap. So that's what's so great about it.
Things we got to pay for allopurinol. I mean, we're all over the place. Our insulins have gone up. What about we're trying to get Januvia?
Get rid of kidney stones. You can pass that. Pass kidney stones.
What about What about hypertensive emergency?
You might be able to pass.
But now we're talking about hypertension. Hypertension only.
We're talking about really bad hypertension.
Exactly. Just think about it. You have a patient, 28-year-old female comes in. She's having a lot of edema. You give her hydrochlorothiazide. Just think how happy she would be. And it's only $4. She can buy that and a gallon of milk.
She's gonna fit in the milk.
Okay, and so the half-life is about 5.6 to 14.8 hours. So, of course, like we said, you can use it for hypertension. And you can also use it for edema. Any other?
And look, I'll even support you in the all-hat trial, and amlodipine chlorthalidone performed very similarly.
It works well.
They did note that they did not use HCTZ, in which case they could not go ahead and generalize those results over to hydrochlorothiazide, and then essentially chlorthalidone, while a little bit more expensive and tougher to get in the United States, has the benefits, but they couldn't prove that HCTZ had the benefits. So there's that. All that.
So just stick to Norvasc.
Well, no, you're going to need
No, hydrochlorothiazide for $4.
Anything else about HCTZ?
No, it's that great.
It's a sulfur
It's that great.
It's a sulfur-containing drug.
No.
Give us your real use.
Okay, so the drug I'm defending, or the drug I chose to defend as the best by far, because a lot of these people in this panel so far have not mentioned one thing, that angiotensin converting enzyme inhibitors have a lot of benefits. Hey, I get it. Hey, look, I get it. It causes, hey, look. You guys are making this side effect a lot more common than it actually is. And let me tell you guys, how common does cough, ACE inhibitor cough? No. I'm not making up this number.
What is Fox News?
I'm not making up. This came from Lysinopro, the drug website, okay? Let me tell you how often cough happens. 3 to 4%. How about ARBs? How about ARBs?
1 to 2%. Mine's lower.
Oh, what's the that's 2% difference. And timing. Hey, look. In the end, everyone makes prescribing decisions based on what? Guidelines, right? Guidelines, and evidence, and time and over. ACE inhibitors have withstood all of you guys, okay? Let me tell you how good it is. Despite all these reported case reports, okay, of death from ACE inhibitor-induced angioedema. Let me just tell you that this is so good that even the expert committees, JNC, ACC, has even made ACE inhibitors. First line for antihypertensive. Look it up, JNC. Look up JNC. It's first line. It is first line. Look it up. ACC, JNC, look it up. As an antihypertensive for patients with essential primary hypertension.
Janet knows a lot about this.
Anyway, so
yes. What happened to your patient, Janet?
Well, despite the fatal side effects, which I will say, disclosure, and I will, because I'm not a fake news person, okay? Yes, it does happen, but let me tell you how rare it is. That is not even, the frequency is not even identified. In less than 1%, it's been reported in post-marketing studies, case reports, among, the other listed fatal.
Treat at least 1,000 people with hypertension. About 10 of them you would.
Well, first of all, out of everyone here, how many people do you treat that is 55, median age 55 or below? How many of you guys have patients with diabetes? How many of you guys have patients with CKD, CAD, PVD? That's pretty much about everybody that we see, right? As internists, as internal medicine doctors. Okay, I can't speak for the family medicine doctors who probably won't prescribe this to their younger reproductive age patients because, they have to worry about fertility issues. And yes. Right, but in the end, again, time and time, it's guidelines is the first line. That's the current status of this blood pressure medicine. It's the number one based on JNC8 and ACC recommendation. It's the first line recommended treatment for primary hypertension, along with maybe 2 or 3 other classes.
You're saying it's as good as you say it is. Why wasn't your drug using Entresto and why was mine using?
I don't know what study you're citing. I don't know. You quote a lot of studies I don't know what study this is.
It was compared to
paradigm.
Hey, look. There's a lot of look. Let me tell you how strong the data is. The data is so strong that it's supported in 4 major trials.
What are the names?
ALLHAT, ASCOT, BPI, ALLHAT, pre-AMI, STOP H2, TRACE, Look it up. All had is lemon. But anyway, so in closing, I forgot to also mention the other desirable properties that a lot of these medications actually cause these effects. It doesn't cause postural hypertension, doxazosine, can't prescribe that in older people. It doesn't cause rebound hypertension because, our patients are not perfect. Sometimes they forget, right? So,
to their renal function right when you start the lisinopril.
hey, look, as a matter of fact, it has renal protective benefits and cardioprotective benefits. Does your medication do that? No.
It reduces.
It doesn't cause hyperuricemia. It doesn't affect lipid profile, which is with my top contender here, the HCTZ thiazide diuretics. Unfortunately, it does cause that. It does affect your lipid profile. It does cause hyperuricemia. And not only that, it's also safe in asthmatics. So you can't use metoprolol in asthmatic patients. And not only that, it's so cheap. You get all these added benefits. Cardioprotective, renal protective, okay? And it's safe in CKD. As a matter of fact, ACC recommends ACE first before ARBs. Not fake news. Not fake news. So, and let me tell you how cheap it is. Let me tell you how cheap it is. That it's on the 450 formulary at Walmart and $5 at Target, okay? And look, they even have combination with this. They have combination medications with lisinopril, HCTZ, lisinopril, Norvasc, all for $4 for a 30-day supply, or $10 if you want a 90-day supply. So, as you can see with our patients, you want to be able to give a medication that everyone can afford. Everyone can. Let's get a card though. How long did the coupons last? Come on. So anyway, in closing, it's the best antihypertensive medication out there that has proven time and time again that even to this day they had to update the JNC7 guideline to include ACE inhibitors as a first-line treatment. Come on. Can you say that about your medication? Probably not. Sure. Anyway, so that's my argument.
Last but not least,
Children. It's time to take a step down because my drug's hydralazine. So hydralazine is in a class of its own. It's a direct-acting vasodilator, acts mainly on arterioles. It is FDA approved to treat moderate to severe hypertension. Look, bottom line, whenever you're treating hypertension, when the cards are down, when you have hypertensive emergency, you're not going to Valsartan. Are you kidding me? You're not going to any of these drugs.
I'm not going to hydralazine either, though.
It's the only one of the panel of 9 that's approved to treat hypertensive emergency. Hypertensive emergency is part of, if we want to talk about, look, hypertensive emergency is going to develop if we don't treat it properly with these guys. You can use my drug. Okay, it's also approved. Okay, it's also approved for heart failure with reduced ejection fraction. It has benefits in African Americans in combination in the drug buy deal with nitrates.
Once again, you rebound another drug just to make this.
It does cause rebound tachycardia. Let me just tell you some other benefits in mine. Man, which one of these works? Is this real? Look, mine has benefits in chronic mitral regurg. In a study with New York Heart Association class 3 to 4, very symptomatic mitral regurg patients treated with oral hydralazine, up to 70% showed sustained symptomatic improvement. That's not enough for you. How about aortic regurg? In aortic regurg, hydralazine, 2 trials confirmed its use that after 24 months they had significantly decreased symptoms and an increase in left ventricular ejection fraction. Okay, so not only are we getting the benefits from the hypertension, also it is considered one of the 3 drugs of choice for treating hypertension in pregnancy and postoperative hypertension. Preeclampsia, you're not going to any of these guys. Okay? Look, we all can write our little scripts in the clinic, and here's your losartan. We look at we raise it by 50 and raise it by 13. When you're in the real hospital, you're not using any of that. Nobody's using any of this stuff in real hypertensive emergency. You're going to hydralazine.
You're
not going to anybody. No, yes. And this brings up a good point that there are other drugs approved for use in hypertensive emergency, none of which are right here. And I'm the only one who has an IV and a PO form, maybe Lopressor, but that's debatable. Of these drugs. Of you guys' drugs. It's not my fault y'all pick bad drugs. I was so glad he brought that up. I'm so glad you brought, because that's what honestly what people think of when they think of hydralazine. They think about drug-induced lupus. Does anybody even know what drug-induced lupus is?
We had a morning report last week.
Okay.
We do know.
It's a skin rash and joint pains. It's not like SLE. It doesn't have end organ damage. It's reversible, and it only happens in 7 to 13%. Yeah, that's an appreciable amount.
Does
But
any other drug cause that on our list?
it's not. Look, I would if I was going to. We all weigh risk and benefits when we write drugs, right? We all do. I think if I was going to write a drug that I really needed it to work, which mine works when the cards are down, and it's real hypertension, not some 150 over 90. I'm talking like 275 over 120.
Okay.
I'm going hydrolysine. I'm not messing with losartan.
You're not doing cardine or something.
What about the patient with coronary artery disease? It
Yeah.
can cause angina and MI.
It does. In fact,
It does not have a black box warning the way that metoprolol's black box warning
American Heart
does.
Association, American College of Cardiology, and Society of Hypertension 2015 put out a scientific statement stating that the treatment of hypertension in patients with CAD, hydralazine should not be used unless in the formulation of Bidil with isosorbide dinitrate. And that's all fine, and that's fine, yeah? Okay, you have to add another medicine, so it's not single alone. However, do you know what the price difference is between hydralazine and the price difference between Bidil?
They're all cheap. Price is not.
Bidil's $306.77.
Yeah, we're not talking about Bidil. We're not talking about Bidil.
But you just were talking about Bidil. We just said
I was talking about mine.
Bidil
Look,
up.
on patients who are intolerant to ACE inhibitors or ARBs, it's actually recommended to use. You can actually write them
You can also write them
dinitrate with hydrolazine. You don't have to write Bidil directly. It actually has. I mean, look, in my personal opinion, when real hypertension matters, it's hypertensive emergency. That's where we have end organ damage. This is where really the cards are down.
That's not the topic.
We're talking about hypertension, right? We're talking about hypertension. We're talking about hypertension. When hypertension gets so bad, these guys go home. They go crying at home. They all go inside. Only one you can use is mine. When hypertension gets so bad that we have to add the word emergency to it, these guys they're just child play. It's true. I'm the only one that's approved for use in preeclampsia or hypertension associated with pregnancy. I'm one of the 3 drugs, none of which are right here. Hypertensive emergency, that's a big category. Okay? It's approved. If you really want to urinate in the ocean, go ahead and try losartan with hypertensive emergency or valsartan. That's even less PPing in the wind. Okay? And if they're pregnant, preeclampsia, you better not use that as a black box warning for maternal fetal dysfunction. So in closing, hydrolazine is the only one that really works whenever hypertension's bad. You want to call it hypertensive emergency and say we're not talking about hypertensive emergency. It's the only one that works when blood pressure is so bad that we give it the word emergency.
So if you can't use these other drugs to get it, okay, then maybe
You would never use one of these drugs.
So now, let's.
Any comments from the faculty?
I know.
Dr. Sells, anybody?
So, couple things we missed. Number 1, perioperative beta blockers. That could have been a speaking point. Number 2, Casey loves prostates. You left that out. Number 3, Janet is our fake news alert. We learned that too.
You gotta be
Okay. And Jason was giving a little bit of fake news just now. Yeah, like a little bit. I didn't mean to call you out, but like a little bit of fake news. Little bit. So, that said, which is the best drug? So our top 3 winners are important. So this is what we're going to do. You're going to go to metoo.com. You can vote for yourselves. Click join meeting.
Where's my iPad at? Hey.
Okay, ready? Whoa. Whoa. Okay, so if we look at this, Rose and Janet, but then we got a 3-way tie. Easy.
We gotta revote.
So revote, but we're only picking one of these 3: valsartan, doxazocin, and HCTZ. Ready? Ooh, valsartan.